Hi, everyone. I'm Joanna with the Resident Fellow and Student section of SIR. Thanks for tuning in tonight to another one of our webinars. Before we start, for those of you who are looking to get more involved in IR, visit our website at rfs.srweb.org. We're always looking for enthusiastic people to join us. Our speaker tonight is Dr. Sean Calhoun. Dr. Calhoun is an attending interventional radiologist at Morristown Medical Center in New Jersey. And he'll be speaking to us tonight about preoperative embolization, focusing on the GI, GU, and reproductive systems. This is going to be an interactive webinar. There'll be questions for you to answer throughout the presentation, but no worries, we're not keeping track of your individual answers. So Dr. Calhoun, thanks for being here, and thank you very much for your time. I'm going to pass it off to you now.
Today we're going to talk about, as Joanna said, preoperative embolization and applications across the genital, urinary, gastrointestinal, and reproductive systems. I'm going to try and make this a little bit interactive for you with some questions and mostly case-based to keep it interesting. It's one of the great things about interventional radiology is that not only do you get to help patients and get immediate gratification for what you do, but you're also helping your referring clinicians, especially surgeons, as an interventional radiologist, making their lives easier, making their surgeries easier. I'm going to show you some examples of that today. But it's really our job to promote this field, to let clinicians know what we have to offer, because it's amazing how unaware some of the clinicians can be about things that we have to offer. And once they're aware of some of these procedures that we can do and how we can help them, we can really be much more involved in helping not only them but our patients. Our learning objectives for this evening are to describe the role of preoperative transcatheter embolization in various gastrointestinal and genitourinary conditions, identify which patients and disease entities may benefit from preoperative embolization, and discuss techniques, indications, and contraindications of some of these procedures. By no means is this meant to be an all-inclusive list of preoperative embolization even within these service lines, but some of the things we're going to focus on today are pre-op tumor embolization, ways to decrease intraoperative blood loss and transfusion requirements and sometimes allow for less invasive techniques. A hallmark example of that is large renal cell carcinomas, which we'll start off with. We'll move into some symptomatic benign hepatic masses. We'll touch very briefly on liver embolization as a bridge to liver transplantation or to convert someone to a resectable status. But these are full webinar topics on their own, so we won't spend too much time on that. Then we're going to move on to small bowel bleeds and difficulties in controlling them and what we can do to localize the small bowel hemorrhage sites for the surgeons. Talk a little bit about portal vein embolization, and then lastly move on to disorders of abnormal placentation and decreasing intraoperative blood loss and transfusion requirements. A very controversial topic. So I thought we'd start off with preoperative tumor embolization. And again, the hallmark for this is really preoperative embolization of the kidney prior to a nephrectomy for large renal cell carcinomas. This was first really described in the 1970s, where embolization was used to treat unresectable renal cell carcinomas or patients who were poor surgical candidates. In the 80s and 90s, more studies came out showing some survival benefit for preoperative renal embolization, particularly with pathologic grade T1 and T2 tumors. That was in a paper by Bono and Carasano in 1983. Kurt Bacall and his group in 1993 demonstrated that patients with large hypervascular tumors with tumor volumes of greater than 250 mLs who underwent complete embolization received significantly smaller mean blood transfusion volumes. And then Schwartz et al. In 2006 showed a trend towards less blood loss in embolized patients, especially in those tumors with tumors greater than 10 centimeters. This just highlights a few of the articles out there in the literature. There are also, to be fair, a number of articles that have shown no significant decrease in blood loss and transfusion rates. This is a typical patient that we would get involved in. Your top is a MRT2 weighted image of the kidney with a large heterogeneous renal mass. Both that and the coronal CTA images, you'll see these large draining hilar veins, large peritumoral draining veins, And on the MRA and conventional angiogram, you see prominent early draining veins, a very hypervascular mass with a significant tumor vascularity, and AV shunting. This is a different patient with a large left lower pole renal mass. He's a 59-year-old male, referred to us for embolization prior to nephrectomy. The video on your left shows an aortogram where there can be seen two left renal arteries and a large capsular artery, inferior capsular artery supplying the tumor. The static image on your right shows this a little bit better. There's two main left renal arteries, a large hypertrophied parasitized inferior capsular artery, all supplying this large hypervascular tumor with abundant vascularity and neovascularity. Embolization is performed with alcohol and a lipiodol mixture. We use a 7:3 ratio of dehydrated alcohol to lipiodol, which has been shown in studies to be the optimal ratio of alcohol to lipiodol. An occlusion balloon is placed in the main renal artery. The balloon is left inflated. It's a compliant balloon so that there's no risk or less risk of intermold damage or rupture of the artery. Balloon is left inflated while the mixture is slowly injected under fluoroscopic guidance. The balloon is then left inflated for 10 minutes to lock the alcohol and lipiodol in place, causes denaturation of the proteins in the endothelium, and occludes the blood supply. Vascular plug or coils are then left behind in the main renal artery. As you see here, vascular plug. In this patient, there were several renal arteries. There were two renal arteries and then an early branching of this division. So this required separate catheterizations with the occlusion balloons in each branch and then in the upper pole renal artery as well. And you can see the contrast staining from the lipiodol evident on the subtraction image. Some residual vascularity from this branch, which was subsequently embolized. Following that, the upper pole accessory renal artery was catheterized, and you see a little bit of residual supply to the tumor here, as well as the normal kidney. This is a superior capsular branch. On the final image, after embolization of the upper pole branch, see some more staining of the lipiodol. There are Amplatzer vascular plugs in the main renal artery, coils in the upper pole branch. And then you're left with looking for the parasitized vessels. We know from the aortogram that there's going to be a large inferior capsular artery which was parasitized, so we've selectively catheterized that. Here's the injection showing significant residual vascularity to the tumor with contrast puddling, tumor staining, and neovascularity. This vessel is a little bit small to be putting an occlusion balloon in, so we chose to embolize this just with embosphere microspheres, and then some coils in the main artery behind it. You get this nice staining of the tumor and of the normal kidney. And this patient went on to do nephrectomy with really no complications, no blood loss. Here's the completion angiogram following embolization, coils in the superior renal artery branch, vascular plugs in the main renal artery, and coils in the inferior capsular artery. You'll notice there is some minimal residual supply still at the lower pole coming off of the left fourth lumbar. You can certainly go in, catheterize that, and put a few particles out. In this case, we chose not to do that and leave it alone, and there was still minimal blood loss. This is another case, a different patient with a 12-centimeter renal cell carcinoma that was embolized preoperatively. Superior aspect of the tumor was supplied by the renal artery. You can see the bizarre neovascularity and hypervascular mass arising exophytically from the lower pole. And if you try and determine where the borders of this mass are, you notice that there's a relative paucity or absence of vascularity in the infromedial portion of this mass. And that tells you there that there's another vessel probably supplying that, which we'll get to in just a second. The image on your right, you see an occlusion balloon in the main renal artery. The same mixture of dehydrated alcohol and lopilodol are injected into the vessel. You see some real dense staining of the normal upper pole of the kidney and staining of the neovascularity in the superolateral portion of the tumor supplied by the main renal artery branch. Vascular plug was placed in the proximal renal artery. And then we had to go and look and see what's supplying the infromedial portion of the tumor. The lumbar artery is a very commonly parasitized vessel in these cases. In this case, the right second lumbar artery was the culprit. This was selectively catheterized. The selective angiogram demonstrates this intense vascular supply to the infromedial portion of the tumor. That was the avascular space seen on the original renal arteriogram. Again, be very difficult to do this with an occlusion balloon in that branch. So this remaining vascularity was embolized with microsphere particles and then coiled proximally. This is what you're left with: vascular plug in the renal artery, coils in the right second lumbar artery, then staining of the tumor and of the kidney itself. Completion angiogram shows complete avascularity and lack of enhancement of any of the kidney or of the tumor. You see the vascular plug in the coils. This patient went on to resection the same day. This is a cross-section pathologic specimen, normal kidney at the top of the screen, obviously the perirenal adipose tissue, and then this large infarcted mass off the lower pole. And if you look closely here, the mass measures about 8 to 9 centimeters. It was 12 centimeters in the same plane on the pre-embolization imaging. So we did achieve some pretty significant size reduction, and this was actually delivered through a hand-assisted laparoscopic port, like I showed you earlier, through just a 9 centimeter incision. The whole specimen was delivered, and this patient avoided an open nephrectomy. So leads us to our first interactive question. This is simply just a poll question. Curious to learn at your institution, how frequently is renal embolization prior to nephrectomy performed at your institution? Do you perform it routinely for large renal cell carcinomas, occasionally and at the discretion of the urologist, rarely, or never?
Okay, so the people who answered, 0% said always, 58% says occasionally at the discretion of the urologist, 0% said rarely, and 42% said never. So it's almost a 60-40 split between B and D. Yep.
Very interesting. So, yeah, I would expect always to not be the case, even at our institution. It's very dependent on the urologist. But as we share our data and our findings with the urologists here, more and more of them have adopted this practice, and urologists who used to say, I don't need embolization, have now started to refer patients to us and have been very glad that they did and very satisfied with the results. Okay. All right, case 3, shifting gears a little bit. This is a 46-year-old female who was referred to us for a uterine fibroid embolization for menometrorrhagia. And as all these patients do, she underwent a pre-embolization pelvic MRI to assess her candidacy for UFE. So in addition to seeing the expected fibroid uterus, there was an unexpected finding in the right ischiorectal fossa, which you see on the 2 MRI images to your left. The T1 FATSAT and the contrast-enhanced FATSAT image demonstrating a densely enhancing mass conforming to the space of the right ischiorectal fossa with a slight mass effect, but densely enhancing lesion. On the T2 coronal weighted images, see areas of relatively bright T2 signal with a layered or whorled appearance. And this is really a kind of a classic appearance for this entity. I'll give you a few minutes as we go through some of this case to think about what you might think this is, and then we'll reveal the diagnosis shortly. So we were asked to embolize this case preoperatively prior to resection with a definite diagnosis in mind. Obviously, it's a very hypervascular lesion, as you can see by the dense contrast enhancement. The surgeon thought that resection would be facilitated by preoperative embolization. So we can kind of predict the vascular supply based on its location. It's either going to be coming from the internal pudendal artery or potentially an obturator branch. So we started with a right internal iliac arteriogram, selective injection, and you see in the distribution of the right internal pudendal artery corresponding with the area of the ischiorectal fossa, you see very subtle but abnormal vessels, slight increase in number and irregularity of the vessels in this area. When we selectively inject the right internal pudendal artery and do a selective arteriogram, see this beautiful dense tumor, relatively dense tumoral enhancement with some mild neovascularity, and you see the actual borders of the lesion very nicely conforming to the adjacent tissue planes. So this was embolized, and I'll lead into our next question. Which of the following agents would you use to embolize this lesion? Would you use gel foam, pushable microcoils, particles, vascular plug, or detachable coils? Okay,
so Dr. Calhoun, 25% said gel foam, and 75% said particles, and 0% for the remaining answers.
Okay, so really the best answer here is particles. Anytime you're trying to affect tissue necrosis, like to get small particles out down as far distally as possible. Gel foam is obviously a temporary agent, and while you could do a gel foam slurry and get more distal embolization, I think particles are really the best choice in this situation. The smaller particles, the better to get down to the tissue level. This patient did have embolization with embospheres, with varying particle sizes, starting with a small caliber to a larger caliber, starting with on the order of 100 to 300 microns, and then towards the end moving up to 500 to 700 micron particles. Following super selective embolization, we go from vascularity that looked like that pre-embolization to significant decreased vascularity on the post-embolization internal iliac arteriogram. And on the selective internal pudendal arteriogram, you see the catheter tip here. You see truncation of the internal pudendal artery with all of the branches essentially occluded, and you no longer see that tumor blush that you did. So the patient went on to resection within 24 hours, actually later that same day. Pathology showed a neoplastic proliferation of cytologically bland spindle and stellate cells in a richly vascular fibromyxoid stroma with many small capillary-sized vessels to medium-sized muscular vessels, with tumor insinuating itself between pelvic muscle and adipose tissue. So by now, hopefully, you've established what you think in your mind the diagnosis is, and this is a classic appearance and pathologic description of an aggressive angiomyxoma of the ischiorectal fossa. These can occur anywhere, but the pelvis is most common site, and the ischiorectal fossa is a classic site. These are benign tumors, but they have a high rate of recurrence due to the inability to resect them completely. They don't metastasize. Distant metastases are exceedingly uncommon, if at all. It's predominantly a finding in women, affects women 90% of the time. As I said, the pelvis and perineum are typical locations, particularly the ischiorectal fossa. And it's a mesenchymal tumor composed of spindle cells, medium-sized vessels, and a myxoid matrix. So the pathologic findings are correlated with the radiographic findings to really cinch the diagnosis. The pathology report is somewhat dependent on the imaging findings as well. And as you saw in this case on the T2 coronal weighted images, it can have very high signal intensity on T2 and that classic swirled or layered appearance that we saw in the coronal image to start the case. Incidentally, this patient 8 months later underwent an uneventful uterine fibroid embolization after recovering from a relatively major operation to resect that tumor. Here's our follow-up MRI to follow up the resected lesion more so than to follow up the fibroid embolization. See just a little bit of residual enhancing granulation tissue, but no residual tumor, and that's been stable now for several years with no evidence of a local recurrence. Her fibroids shrink significantly as well, with several small necrotic fibroids compared to the larger fibroids preoperatively. Case 4, this is a 37-year-old male with chronic worsening epigastric pain, early satiety, and occasional nausea. Had an extensive workup, which was essentially unrevealing except for a CAT scan showing this large mass in the lateral segment of the left lobe of the liver with a smaller lesion in the medial segment. Most of you will appreciate the classic peripheral nodular enhancement pattern and quickly recognize this as a hemangioma. This is a coronal T2 weighted image, which shows the relatively bright signal intensity of a hemangioma. This one measured 12 centimeters. By definition, is a giant hemangioma. So this is symptomatic giant hepatic hemangioma measuring 12 centimeters. A giant hemangioma refers to any hemangioma greater than 5 centimeters. In terms of treatment for these, observation is recommended for asymptomatic lesions with surgery, embolization, radiotherapy, or RFA for symptomatic lesions. Surgery can involve enucleation, lobar resection, or on rare occasions actually could require transplant if the tumor is large enough. Complications are typically bleeding or rupture or compression of adjacent organs, such as in this case in a patient who presented with early satiety. It can also present with chronic pain, but you must exclude all other causes for the patient's pain prior to attributing it to the hemangioma, because most of these are asymptomatic. Hemangiomas can also present with Kasabach-Merritt syndrome, which is a consumptive coagulopathy characterized by severe thrombocytopenia, hypofibrinogenemia, and elevated fibrin degradation products and fragmentation of the red blood cells. This has been more recently debated as to whether these are truly hemangiomas when they present like this, or a number of these have since been recategorized or reclassified as Kaposiform hemangioendotheliomas, which is a variant. So in fact, the association of Kasabach-Merritt syndrome with giant hemangiomas is to some extent debated. Treatment options, as mentioned, include surgery, embolization, radiotherapy has been used. Radiofrequency ablation is really difficult for these larger lesions because you're limited by tumor size. And preoperative embolization has been used prior to surgical resection. Embolization has also been used alone. This patient was actually referred for preoperative embolization with the thought of doing a left hepatectomy to remove the lesion. So the patient presented to us. This are the angiogram images. You see a cobra-shaped catheter in the common hepatic artery. This is the gastroduodenal artery into gastroepiploic artery. And you see this enhancing mass with peripheral contrast puddling, correlate of what you see on CT, typical of a hemangioma. In this case, there are really 3 vessels supplying the hemangioma. The other lesion I showed you on CT is here, and that's more of a rapidly enhancing hemangioma. These giant hemangiomas fill very slowly due to their size. This is a selective injection into the left lateral hepatic artery branch, and a slightly later stage where you start to see more peripheral contrast puddling and pooling, filling in. But these will rarely fill in completely when they're this large. Following embolization with microsphere particles, the 2 superior branches are completely gone. The 3rd inferior branch of the left lateral hepatic artery is pruned, and you see resolution of the peripheral nodular enhancement. We obviously left the smaller hemangioma alone. This patient's symptoms improved so dramatically and so quickly that the need for surgery was obviated, and the patient has remained asymptomatic up until his last visit with us. Case 5, 38-year-old female with hypertension and anxiety, presents with worsening chronic right upper quadrant pain and pressure. She awakens her at night, so severe that she presented to the emergency room on one occasion. She has a known liver mass about 6.7 centimeters. It's been followed. It's been stable in size for 4 years. She's been on oral contraceptives from age 15 to 35, and upon discovery of the liver mass, was taken off of oral contraceptives. So she presents acutely to the emergency room with pain. Imaging studies had been performed, and you see it from the inframedial portion of the liver. You see a mass, exophytic mass arising, relatively attenuating to liver, with a small central scar. On MR, T2 weighted coronal image, liver again is iso-intense to normal liver, maybe slightly hyperintense with a bright central scar. And on the 20-minute delayed hepatocyte phase with gadoxetate, otherwise known as Eovist, I see dense enhancement on the hepatocyte phase. These are all the classic imaging findings of a focal nodular hyperplasia. The patient had an extensive workup, and pain was attributed to this lesion. The rest of the workup was negative and unrevealing. She was therefore referred for embolization prior to resection. A diagnosis of focal nodular hyperplasia. And this is a really impressive arteriogram. This is a arterial phase image from a common hepatic artery injection. You see the proper hepatic artery and this densely enhancing mass being supplied by inframedial branches of the left hepatic artery and by anterior inferior branch of the right hepatic artery. What's really striking is not just the dense enhancement of the lesion, but notice the lack of significant opacification of the intrahepatic arterial branches. And that's due to a sump effect with the contrast just being sumped into this richly hypervascular lesion and being sumped away from the normal supply to the liver. So both the right anterior inferior hepatic artery branch and the left inframedial branch were catheterized with a microcatheter. Embolization was performed again with particles. In this case, 100 to 300 micron embosphere particles were utilized. And following embolization, what's really striking is not only is the mass devascularized, but look, once that's accomplished, look at the dramatic increase in intrahepatic blood flow now that the sump effect has been taken away. So this patient, much like our hemangioma patient, had significant improvement after embolization, and actually to date has not required surgical resection. Focal nodular hyperplasia, again, is a female, more predominant disease with a ratio of 6 to 8 to 1 as compared to males, typically ages 30 to 50. The link to oral contraceptives in focal nodular hyperplasia is uncertain. General recommendations currently are that there's no need to stop oral contraceptives, but if you're going to continue on oral contraceptives, to consider follow-up imaging at 6 to 12 months. This does not have any malignant potential. These are almost always asymptomatic, with resection and intervention reserved only for symptomatic patients, typically due to large size or due to pressure on the liver capsule. Embolization for FNH was first reported with ethanol in 1989 and has been used as an adjunct to surgery or as an alternative to surgery. In this case, it was planned as an adjunct to surgery, but was actually converted to being an alternative to surgery as the patient's symptoms improved enough that she chose to forego surgical resection. Next case is a similar case, 32-year-old female with a sudden onset of severe right upper quadrant pain, presents acutely to the emergency department with an acute onset of pain, hemoglobin and hematocrit of 11.2 and 34 on admission. On further questioning, she also reports chronic nausea requiring her to eat small meals. She also has been on oral contraceptives for over a decade. A CAT scan was obtained through the emergency room showing a large hemorrhagic mass occupying the anterior portion of the right lobe of the liver and a large portion of the left lobe of the liver. It was actually an area of sentinel bleed or active extravasation into the mass here. So she was referred for urgent embolization with the thought of resecting this lesion after it was embolized and she was stabilized with the diagnosis of a hemorrhagic hepatic adenoma. This is an arteriogram with injection into the left hepatic artery through a prograde microcatheter advanced through a reverse curve sauce-shaped catheter. Injection reveals this hypervascular mass. You can see the vessel splayed around the border of the mass and outlining the mass nicely with increased vascularity throughout. This was predominantly supplied by left medial branches. The left lateral hepatic artery branch was selectively catheterized and really was contributing minimal supply to this lesion. Therefore, embolization was performed through the medial left hepatic branch. 300 to 500 micron embosphere particles were used in this case. Follow-up angiogram demonstrated significant decrease in vascularity to the lesion. The patient did well for several years and was discharged 4 days later after this procedure. She was followed. The mass continually decreased in size. However, about 2.5 years later, on follow-up, the lesion had started to enlarge again. The patient remained asymptomatic but was referred for embolization, and obviously never had gone on to resection prior to this. So here's the lesion now. So it had progressed in size, but you'll notice it's still significantly smaller than when she originally presented. You'll notice also a second small adenoma in the lateral segment of the left lobe. So again, she was referred for further embolization. And on the repeat arteriogram, you see new vascular supply from the medial and lateral branches of the left hepatic artery. This was further embolized with both the medial and lateral hepatic artery branches catheterized with a microcatheter. Embosphere particles, this time smaller particles, 40 to 120 micron and 100 to 300 micron particles were used. These are selective injections, again demonstrating the residual or recurrent vascularity to the lesion. And following embolization, you see truncation of the feeding arteries, really an avascular lesion at this point. And to date, this lesion has not been resected, and the patient has been asymptomatic. In terms of hepatic adenomas, risk factors include women of childbearing age or on oral contraceptives, anyone with a history of glycogen storage disorder, or males on anabolic steroids. Once they hit 3 to 4 centimeters, there is an increased risk of bleeding or malignant transformation, so therapy should be considered at that point. Treatment is variable. It can start with simply cessation of oral contraceptives, resection, embolization, and for very large tumors on a rare occasion may even require transplant. Next case, 86-year-old male with a 10.5 by 9 centimeter biopsy-proven hepatocellular carcinoma involving both the anterior and posterior segments of the right lobe of the liver. Due to the patient's age and comorbidities, he was not felt to be a surgical candidate and was referred for embolization. At our institution, we typically embolize our hepatocellular carcinomas with bland embolization. This could certainly be done with chemoembolization or Y90, depending on your protocols. I'm going to go through this fairly quickly because we could spend a whole couple of webinars on Y90 and TACE, etc. But here's the lesion in the right lobe of the liver. Only a few after 2 embolization sessions, the initial arteriogram shows this hypervascular mass with a neovascularity, and selective injection, a larger magnified view shows this to better detail. This was embolized with graduated particles, starting smaller particles and working our way up to larger particles. And after only a few months, you see a dramatic reduction in size. Now, this patient still is not felt to be a candidate to surgery, but you can see how treating a large lesion like this and shrinking it down to a smaller status would make surgery a lot easier. And this patient, if not for his age and comorbidities, would now be a much better surgical candidate. Now we're going to shift gears a little bit away from the tumors and start talking about small bowel hemorrhage and GI bleeds. Small bowel has been referred to as the dark continent of the GI tract due to its long length of approximately 5 millimeters, limiting ability to visualize and diagnose pathology in the small bowel. Capsule endoscopy can be helpful, but it's still very difficult to localize, diagnose, and treat lesions in the small bowel. Etiologies you see listed below include vascular and neoplasm are the most common causes in older patients, and in younger patients, Meckel's diverticulum, Dulafoy's lesions, and Crohn's disease would be the most common causes. Small bowel hemorrhage can be very difficult to treat through embolization. Technical success rates range anywhere from as low as 40% to 100%, and rebleeding rates are very variable in the literature, ranging anywhere from 0 to 40%. Options include embolization, surgery, and if all else fails, good old-fashioned vasopressin therapy into the SMA. Tools to evaluate small bowel hemorrhage is very difficult to localize. Sometimes you go to extreme efforts, and these patients go through exhaustive workups to locate their site of hemorrhage. Capsule endoscopy, enteroscopy, and even double balloon enteroscopy, which is more of an advanced endoscopic technique to localize small bowel hemorrhage. So we'll move right into our first case, 88-year-old female with recurrent lower GI bleed. Workup included a double balloon enteroscopy revealing active hemorrhage, likely due to an AVM in the small bowel. Enteroscopy failed to reach the level, and the patient then presented with recurrent hemorrhage and a little bit more of extremis, and a bleeding scan was performed. Bleeding scan shows an area of active hemorrhage conforming to a small bowel loop in the mid to lower abdomen. She went straight to angiography on this late arterial SMA, late arterial phase of SMA arteriogram. It looks really quite normal from far away. Take my word for it, there's a very subtle finding here, which you can see better on the workstations. But if you look closely, there are two paralleling vessels here, and just a slight increase in vascularity in this area. So we went out and selectively catheterized and injected that vessel. And this is the selective arteriogram image. So based on this image, I'll ask you quickly, because I know we're running a little short on time, what's your diagnosis based on this image? Adenocarcinoma of the small bowel, carcinoid, diverticulosis with hemorrhage, Dulafoy's, or an AVM of the small bowel?
Okay, so 88% answered AVM and 13% answered jejunal diverticulosis with hemorrhage.
Okay, so 88% have it. This is an AVM of the small bowel. If we look up closer imaging, you'll see multiple tiny tortuous feeding vessels highlighted in yellow, supplying this nidus of the AVM with an early draining vein highlighted by the red arrow. And throughout the procedure, you see this dense contrast staining and extravasation opacifying the lumen of the small bowel. Due to the multiple tiny little feeding vessels, selective catheterization of each of these vessels was not possible, and consideration was given to embolizing this with N-butylcyanoacrylate, which is probably the best embolic agent to use for small bowel AVMs, but it's just not technically possible to get distal enough to do this and get all the branches. So we elected to place coils in the main parent feeding artery as far out as we could get them to occlude all of the distal branches. And the patient did okay for a little while. Several days later, however, the bleeding recurred, and the patient was taken to the OR for definitive laparoscopic small bowel resection. The coils were instrumental in helping the surgeon localize the appropriate small bowel loop. So this is an intraoperative photograph on the left with surgical hemostats placed over the field to localize the small bowel loop. This was all done in laparoscopically. The coils were able to be palpated and localized fluoroscopically, assuring resection of the correct small bowel loop. as otherwise these things are incredibly difficult to localize and find intraoperatively. Just for confirmation, the surgical specimen was radiographed, and you can see the embolization coils in the specimen and the suture lines from the resection margin. The patient went on to a full recovery. So next case is another case of a small bowel hemorrhage. This is a 68-year-old male with a history of metastatic renal cell carcinoma on Coumadin for atrial fibrillation, who presents with recurrent melena. He had an extensive outpatient workup over several weeks. The upper and lower endoscopy negative. Video capsule study suggested a small bowel source. A double balloon enteroscopy revealed a slight erosion at the site of a prior small bowel resection anastomosis, and push enteroscopy to 120 centimeters failed to reveal the source. The patient was then admitted with an acute episode of GI bleeding requiring 11 units of packed red blood cells. Bleeding scan was performed but was negative, and he was sent to the IR suite. This is an SMA arteriogram based on the results of the capsule endoscopy. We expected the lesion to be somewhere in the mid to distal small bowel. And again, at first glance, this looks fairly unrevealing. You're always taught to look at the edges of the film, right? And it's a very subtle abnormal contrast blush here, which will become more apparent as I show you a magnified image. So here's a contrast blush. This is an unsubtracted image now, so you've eliminated all the bowel gas motion artifact that you see throughout, leaving just this contrast blush here. The feeding vessel was selectively catheterized, and a selective injection shows this to better detail. You see this densely enhancing mass with several vessels supplying it. This patient had already had a known renal cell metastasis to the small bowel, which had been resected previously, so this was suspected to be the same. And this patient obviously had to go to resection to remove the mass. In the interim, we placed coils in the main feeding arteries, both to help the surgeon localize the loop for resection and to temporize the bleeding and get control of a more acute situation to allow for a more controlled environment for surgery. So this did arrest the bleeding for some time. The patient was able to be stabilized and taken to the OR the following day in a more controlled manner. The coils were localized intraoperatively, and the small bowel was resected, and in fact it was a 2.4 centimeter metastatic renal cell carcinoma involving the full thickness of the bowel wall with a little serosal, mucosal ulceration rather. Going to move on to portal vein embolization. I'm going to do this fairly quickly as well because I know there are separate webinars on this, but we'll show one quick case. This is a 74-year-old male with progressive metastatic colon cancer to the liver despite RFA and chemotherapy. Disease progressed and was limited to the medial segment of the left lobe and to the right lobe, and he was referred for preoperative portal vein embolization prior to trisegmentectomy. You see the disease in the liver, and pre-op future liver remnant volume was 23%, which is really just pretty marginal. In a normal liver, you want a minimum of a 20% future liver remnant volume, and someone who's seen a significant amount of chemotherapy. As this patient, 30% is probably a better number. So I think maybe, Joanna, in the interest of time, we'll skip the actual polling here and let you think about this. Does that sound good?
Yep, that's fine.
Okay. So which of the following is not a commonly accepted route for portal vein embolization? The ipsilateral percutaneous transhepatic approach, a contralateral percutaneous transhepatic approach, intraoperative transileocolic venous approach, percutaneous transsplenic, or transjugular intrahepatic portal approach. And the answer is D, the percutaneous transsplenic approach. All the approaches have been used. We'll talk mainly about the percutaneous approaches, ipsilateral and contralateral, as those are most common. Intraoperative approach is used very commonly in other countries, or can be used if the patient is requiring a intra-abdominal surgery for some other reason, in which case the catheter is placed into the ileocolic vein under direct visualization in the operating room, and embolization is performed through that. And it can also be performed through a transjugular approach. So this is the current patient. This was performed via an ipsilateral percutaneous approach. So a peripheral portal vein radical is accessed with a needle, a sheath is placed, and a catheter is placed in the main portal vein. Portal vein pressures are measured because portal hypertension is a contraindication. And portal venography is performed to assess the anatomy and make sure there's no variants, or to know what the variants are if there are. This is just a later phase image. The disadvantage to an ipsilateral approach is that catheterization of some of the ipsilateral lobar branches can be difficult, or should I just say slightly more difficult than the contralateral branches, where it's really straightforward. This usually requires a reverse curve catheter to come back in and hook these branches and to embolize it. Once you've embolized with particles, you can also use several other embolic agents, including glue. We use particles here, and then you want to coil the main vein after the particle embolization. Obviously, you save the access vein that you used for last, so that you can embolize that on the way out. And then we embolize the tract also to minimize the risk of subcapsular hematoma and bleeding from the liver tract. In this case, we use a combination of plugs and coils to plug the main portal vein branches, and then coils in the tract. So pre-op future liver remnant volume was 23%. Post-embolization several weeks later was 37.6%, so we had significant hypertrophy. And then post-extended right hepatectomy, you see the further hypertrophy of the lateral segment of the left lobe. Despite all this and a pretty satisfactory future liver remnant volume, this patient's post-op bilirubin bumped significantly and peaked at 14.2. He had a little bit of a rocky course before the bilirubin nadired at 1.8, and the patient was discharged. Portal vein embolization, again, the idea is to promote hypertrophy of the future liver remnant prior to extended hepatectomy in patients with potentially inadequate future liver remnant volumes. You should really be talking about the SFLR, which is a standardized future liver remnant volume, and that's a percentage of the total liver volume, because depending on patient size, larger patients need larger livers. So your future liver remnant volume should be calculated as a percentage of your normal liver. You can use the body surface area equation to calculate your total liver volume rather than measuring the entire liver volume manually. Also, it should be noted that regeneration actually occurs more by hyperplasia, the increase in number of cells. Sorry, there's a typo here, rather than by hypertrophy, so it's a little bit of a misnomer. Regeneration happens by intra and extrahepatic stimuli. Larger hepatic insults induce more global hypertrophy, so if you have a very localized insult to the liver, that will cause some local hypertrophy, but if you get a larger insult to a larger percentage of the liver, the entire liver will actually start to hypertrophy and respond. Hepatocyte growth factor and mitogenic factors are likely responsible for some of the hypertrophy, and you see peak mitotic activity in the regeneration in about 3 to 4 days, with a plateau at 7 to 14 days. Note diabetics and cirrhotics respond slower than normal livers. This is indicated for both primary and secondary hepatic tumors. Again, a good number to remember is 20 to 25% FLR in patients with normal livers. That should be your target. 40% in cirrhotics and 30% in patients with hepatic fibrosis, or have seen a lot of chemotherapy, or have had severe hepatic injury for other reasons. Patients undergoing extended right hepatectomies, in vast majority of patients, over 90%, segments 2 and 3 account for less than 20% of the liver volume. So in almost all patients undergoing extended right hepatectomy, almost all of them will benefit from a right portal vein embolization, and also embolizing segment 4 as well. Again, we talked a little bit about the approaches, quickly the pros and cons. The ipsilateral approach avoids damage to the future liver remnant, so you're not percutaneously sticking the future liver remnant that you're leaving behind and potentially injuring that portion of the liver, which you're trying to actually promote to hypertrophy. However, the contralateral approach is technically easier to perform. but the vast majority of people utilize the ipsilateral approach to avoid damage to the future liver remnant, and then you can easily place coils in the tract and prevent bleeding. The other two routes are significantly less common, although the transileocolic venous approach was actually the first described and is more common in other countries. Very briefly, just want to mention the idea of combined arterial and portal embolization. That involves doing both a transarterial embolization followed by portal vein embolization 3 to 4 weeks later. This may actually increase the rate of hypertrophy and the volume of hypertrophy compared to portal vein embolization alone. And what the real nice thing about this is it allows for local control of the metastatic disease while you're waiting the 3 to 4 weeks for hypertrophy. So you do your portal vein embolization, patients may off chemotherapy, off any other treatment for 3 to 4 weeks while they're waiting for the liver to hypertrophy. And after portal vein embolization, you see a significant increase in arterial flow to the liver. That's called the hepatic artery buffer response, and that can actually promote tumor growth while you're waiting for the future liver remnant to hypertrophy. So this is performed, most of the studies describe this with TACE, 3 to 4 weeks prior to portal vein embolization, and studies have shown an increased rate of tumor necrosis, a higher 5-year disease survival rate, and increased future liver remnant hypertrophy compared to portal vein embolization alone. Contraindications we mentioned include overt portal hypertension because resection itself is contraindicated. Normal portal venous pressure should be 5 to 10 millimeters of mercury. Major portal vein invasion is a contraindication because the blood flow is already diverted. Patients with significant extrahepatic metastatic disease are really not good resection candidates in the first place, and untreated biliary obstruction. So if somebody has biliary obstruction, that needs to be dealt with first. Various agents can be used. We use particles here, but some have promoted NBCA as being a better agent, but that's really user preference. And results, you see anywhere from increase in future liver remnant volume starting from 19 to 40%, and post-embolization ranging 31 to 60% in one paper. There's a relatively low complication rate. You should note that diabetics and patients with chronic alcohol use and malnutrition typically hypertrophy less well. All right, on to our last topic. This is a 31-year-old female post-evacuation of a 10-week pregnancy, subsequently developed bleeding for the next 5 weeks. Ultrasound and MRI suggested retained placenta increta. These are sagittal axial coronal MRI images demonstrating retained placenta deep into the myometrial wall, again suggestive of retained placenta increta. Patient was referred for a preoperative embolization prior to a definitive hysterectomy. Quickly, poll question number 5. Acceptable treatment options in this situation include leaving the placenta in situ, hysterectomy, embolization followed by hysterectomy, methotrexate, or all of the above. Again, I think we'll just do this one kind of on the fly in the interest of time. The answer here is all of the above. One of the more common methods of treating this is leaving the placenta in situ and allowing it to regress spontaneously, which we'll do very frequently. In this case, we're 5 weeks out and she's still having heavy bleeding. Something needed to be done, so she underwent embolization followed by hysterectomy. Methotrexate has been advocated, although the data is really not convincing that that's effective. It is still a treatment option consideration. This is a flush pelvic arteriogram in our patient that you saw the MRI of. You see hypertrophied bilateral uterine arteries, left greater than right, with increased vascularity. Selective injection of the right and left show this to better detail. And post-embolization with embosphere particles and microcoils in the uterine arteries results in devascularization of the uterus. The patient went on to hysterectomy uneventfully with no bleeding or transfusion requirements. Last case is related. This is a late 3rd trimester pregnancy, and this woman is is pregnant. This is not a pregnancy that was lost. Her ultrasound images suggested a placenta percreta possibly invading into the urinary bladder, and she was referred to us to see how we could help. So in a pregnant patient with disorder of abnormal placentation, which of the following is true? Embolization immediately prior to delivery is warranted. Delivery followed by bilateral internal iliac artery ligation is the management of choice. Placement of an occlusion balloon catheter prior to delivery is best placed in the distal abdominal aorta. Or occlusion balloon catheters should be inflated in the internal iliac arteries immediately after the umbilical cord is clamped. So the answer here is D. Occlusion balloon catheters should be inflated in the internal iliac arteries right after the umbilical cord is clamped. Obviously, choice A, you don't want to do embolization prior to the delivery. Delivery followed by bilateral internal iliac artery ligation is an option, although due to the vast collateral supply to the pelvis, that typically does not do a whole lot to minimize blood loss, although that is one of the methods used. And occlusion balloon should not be placed in the distal abdominal aorta. The rate of complications is higher, and due to the collateral network, that's going to do very little to decrease bleeding. So abnormal placentation can arise from the mildest form with placenta increta, where the placenta is just slightly embedded into the uterine wall, placenta increta, where there's deep myometrial invasion, and then placenta percreta, as was suspected in this case, where it's actually invading through the wall and into adjacent structures, typically the urinary bladder. In the 1980s, these disorders of the placenta were seen approximately 1 in 2,500 deliveries, and then by the 1990s, that had increased to 1 in 533 deliveries due to the increase in cesarean sections, placenta implants on the C-section scar, and subsequent pregnancies, and puts you at risk for invasion into the myometrium and potentially through the myometrium. Because of the location of the C-section scar, coexistent placenta previa is very common, been reported to be as high as 88%. These are really significant disorders associated with massive blood loss, even with hysterectomy performed at the time of cesarean section. Average of 3 to 5.5 liters of blood loss. Up to 90% of patients will require transfusion. Up to 40% require transfusion of greater than 10 units of packed cells, and maternal mortality is as high as 7%. So one of the options is prophylactic internal iliac artery balloon occlusion for these disorders. This is a controversial topic and has been since the beginning of time. The idea is to reduce blood supply to the uterus and to the pelvis by decreasing the pulse pressure to the uterus. You're not going to completely devascularize and completely occlude all blood flow by putting these catheters up, but you're trying to decrease the pressure, allow better visualization of the surgical field, and minimize your blood loss. These cases are very complex. They require extensive planning and a true multidisciplinary approach with OBGYNs, interventional radiology, anesthesia, blood bank and hematologists potentially, and blood specialists, as well as urologists if there's a bladder invasion. And really, planning is key here. Once the catheters are in place, it's essential to minimize patient motion. If the patient's going to need ureteral stents, you don't want to be putting the patient in lithotomy position and have the balloons migrate. Even something as simple as a Foley catheter and moving the legs to place a Foley catheter in can dislodge the catheters, and that's when you're set up for the complications that have been reported. So the literature is mixed. There are many reports of decreased blood loss and decreased transfusion requirements. However, there are also a number of reports of significant vascular complications, including thrombosis and pseudoaneurysm, probably due to balloon migration. The American College of OBGYN issued this opinion in 2012 that evidence is insufficient to make a firm recommendation on the use of balloon occlusion or embolization to reduce blood loss, but individual situations may warrant their use. Despite initial enthusiasm, available data are unclear regarding its efficacy. Although some have reported reduced blood loss, there have been other reports of no benefits and even of significant complications. Now, the flip side to that is some of the other literature out there. It's a nice paper in 2007 in the AJR showing a statistically significant decrease in mean blood loss and mean volume of blood transfused, as well as the duration of surgery with no catheter-related complications in 11 patients. And then this article from the Seminars of Interventional Radiology did a very nice comprehensive review of the literature. And of the 39 patients reviewed in the literature, there were no catheter-related complications. They documented the successful management of placenta accreta and with preoperative balloon catheters in the hypogastric arteries or other arteries supplying the uterus. Occasionally be placed in the anterior division of the internal iliac artery, or rarely in the uterine artery itself. So just in conclusion, to summarize, and we went through a lot of material here, preoperative embolization of hypervascular tumors such as renal cell carcinoma increases safety and improves outcomes of surgical interventions by reducing blood loss and allowing for conversion to less invasive surgical techniques. In some cases, as in some of the liver cases I showed you today, embolization may obviate the need for resection. GI bleed in the small bowel may not respond as well to embolization as it does in the colon. In these cases, or in cases in which surgical resection is planned, preoperative coil embolization can serve as a landmark for intraoperative localization and curative small bowel resection. In cases of small bowel AVMs and angiodysplasia, and BCA may be the preferred embolic agent. Embolization of hepatocellular carcinoma and hepatic metastatic disease with either bland embolization, TACE, or selective internal radiation therapy may serve as a bridge to transplant or may convert unresectable disease to a resectable status. Portal vein embolization prior to hepatic resection causes preoperative liver hypertrophy in patients with suboptimal future liver remnant volume prior to major hepatectomy and results in improved surgical outcomes. Staged arterial and portal vein embolization may be beneficial. And in pregnant patients with disorders of abnormal placentation, consideration should be at least given to preoperative placement of bilateral internal iliac artery occlusion balloons. And embolization procedures are constantly evolving. Many have evolved into standalone therapeutic modalities that have started out as being adjunctive procedures. We saw that with uterine fibroid embolization. I'm starting to see that with prostate embolization, and several examples that I showed you with benign hepatic masses where surgery was the need for surgery was obviated following embolization. These are my references, which will be posted as well. And I thank you very much for your time and attention.
I as well thank you. All of us thank you for your time and your presentation. I know that attendings are busy, and it really takes a lot of time to put together a presentation like this. So we all thank you from the RFS.
Okay, well, thank you very much for organizing this, and thank you for everyone's time and attention. You guys are doing a remarkable job with the resident and fellow section, and I encourage everybody to get involved and join if you're not already.
Okay, thank you everyone for coming out to our webinar tonight, and have a good night.